Good morning, everyone, and welcome to Cardiac Grand Rounds for May 27th, 2025. Today, it is my great pleasure to introduce Dr. Isma Rafiq. She is visiting us from the Royal Brompton in UK. Isma is an extremely experienced and talented cardiologist. She is a congenital cardiologist. She has expertise in high-risk pregnancies, and she does congenital cardiac MRI. So very impressive background. Prior to the Royal Brompton, I believe you were at Leeds and went to medical school in East Anglia. So fully UK trained, but we're trying to get her very interested in Canada. Okay, welcome, Rafiq.
No, thank you so much. Right. So let's start. I think I've chosen a very challenging topic, but I think it's interesting. I think cardiovascular imaging and pregnancy can go hand in hand. But let's see how we do today with this. And I'll be quite interested to know that what your practice is and how do you manage your cases, and I think it'll be quite nice to reflect and see how we can make things better for these women. I take women very seriously, actually, being there and done it all. Right. Oops, this is not moving. So I think when we look at pregnancy and heart disease, our go area is the echocardiogram. So we look at imaging, and most of the time, most of the patients with pregnancy and heart disease are set through pregnancy with echo data. These are different images which have come through for pregnant ladies from different hospitals, district hospitals, that take a video clip on an iPhone, they send it, what do you think about this? Does that need to be seen or not? Can you please sort this patient out for us? So I find it very interesting when I get a WhatsApp message with no info on it, apart from saying, can you please look at this image for me? So let's talk about pregnancy. We do know that during pregnancy, your heart rate, stroke volume goes up, hence your cardiac output goes up. Your plasma volume goes up. So if your cardiac output is around normal 4.5 to 5.5 liters, you can go up to 6 to 8. And if you've got twin pregnancies, I think then you're doomed with your cardiac output. At the same time, your systemic vascular resistance and your blood pressure drop. And we have to keep in mind there should be, if there are other stresses, if you develop hypertension, preeclampsia, things do dramatically change. When we go through labor, cardiac output increase as well as the preload, and you do have the sympathetic stimulation. And I think that's the most challenging time in a woman's life when you're delivering a baby. I think you're between life and death at that time. Things can go wrong, then you're gone, or you end up with serious morbidity. And if they go well, then it's all happy ending. And then as soon as you deliver, things more or less go back to normal. So is pregnancy simple with heart disease? No, I would say. Where you have the underlying diagnosis of congenital heart disease, valvular heart disease, cardiomyopathies, pulmonary hypertension, what other factors can affect your pregnancy when you have an underlying diagnosis of heart disease is obesity. You can be smoking, you can be a heavy drinker, you can be abusing drugs, hyperlipidemia, and such sort of things. I wouldn't talk about Medicare because we don't have that. This is a very American-based paper. So that's not party to it at all in the UK. We don't care because we treat everyone one and all via NHS. And then at the same time, we look at the obstetric factors. You have to be careful, as I was saying, that if you develop pregnancy-induced hypertension, you have eclampsia, preeclampsia, there are a number of things that can complicate a cardiac pregnancy as well. So it's very important that if you're counseling someone, you address the modifiable risk factors. The one that you can't modify is your race, age, and anticoagulant use. If you've got metallic valve, you have a metallic valve. You have to manage it, and you have to keep in mind there's a 10% risk of dying if your coagulation is not managed effectively with a metallic valve. So I would say that if that happens and things get complicated, the risk of maternal death is very high, and there can be lots of other complications with that. We use the WHO classification, and the guidelines are from 2018. Class 1, Class 2, I think I can fall asleep with. When we start falling into Class 2 and Class 3, you start getting a bit worried, and then I will go in detail in the coming slides. Class 3 is high risk, very worrying, with a high risk of mortality and morbidity. And Class 4, we normally say, please, for goodness sake, don't fall pregnant. But at the same time, I have to say that we have delivered quite a lot, which have been in class 4. Now, what imaging modalities can help us? Echo's great. I think echo's done the job. You can pick up everything that you like to pick up on echo, but sometimes your windows can be very limited if you are pregnant at the time. And I think with the aorta, that can be a big challenge. Then you can use MRI. We do use MRI in pregnancy, especially if we do have Marfan's with the aortic root, or we've seen change in the aorta size in pregnancy, ideally after the first trimester. And if we are not sure about the diagnosis, then we probably will go for it. We had we found a tumor during pregnancy as well, and we were not sure what that was, and then we used MRI. CT is less common, and the reason being that high radiation risk, but I have to say it's more easily available than MRI. So with echo, as we all know, that we are able to see most of the pathology, but we will struggle with acrostic windows, and we do know that we don't need to give GAD and there's no radiation. CT, radiation and contrast is a problem. You can do MRI without contrast, but then it depends upon what sort of images you got and what is the yield at the time. So why we worry about CT? I think this is the most important slide. If your radiation exceeds 100 mgy or megacigawatt, then there's a risk of miscarriages, fetal deformation, and even if you do them later in life, there's a problem with the IQ as well, as they say, according to research. And then you can say with MRI, if you're pregnant, you're doing MRIs again, but there have been MRIs very, very safe during pregnancy. At Guy's and St. Thomas's, while I was doing my research as well, they have developed certain programs where they're scanning fetuses for neurodevelopment. As a part of the research program, we do lots of cardiac scans for cardiac anomalies if we are not sure on the echocardiogram, and that's a common thing now, that most of the fetuses get a cardiac MRI to look through their heart anomalies. We all know that during pregnancy that everyone adjusts or adapts. The LA diameter increase, LV volumes increase, aortic root ideally should not change, but there has been some literature out that you may get a change of 1 millimeter to 2 millimeters. And also LV masses increases, but you have to be mindful of the fact that if you've got hypertensive heart disease during pregnancy, your LV mass will be much bigger. So don't be alarmed. Once everything is sorted, things will settle. Now, I found this study very, very interesting, and I have to say I wasn't aware. So they basically looked at all the congenital patients and looked at the right side of the heart, and they basically find that RV systolic function and RVPA coupling is basically associated with adverse pregnancy outcomes. And they also said that the factors don't go back to a normal after delivery, which was very interesting, but what they don't know is what is the long-term outcome. So I think this can be someone's research project that they can, if you've got a big collection of TOF with RV dilatation, pulmonary valve regurgitation, you can basically use that and see the long-term outcomes. For example, we have got a big cohort of tetralogy fellow, and I always say that we basically sit lots of patients through pregnancy with severe pulmonary regurgitation, dilated RV. We say, oh, it's a regurgitant lesion, nothing's going to happen. But none of us know. We may get them through pregnancy without any problem, but none of us know in the long term what's their risk of arrhythmias, what their MACE will be, will that RV remodel? We don't know about 10 years down the line that have we done them a good job, or have we introduced more fibrosis by overloading that RV during pregnancy? So that's something that we can do as a research study. And I don't think there's any data out there, and I looked through quite extensively. Again, I found this paper as well, and I was like, They looked at different types of pathology in congenital heart disease. They'd done different echoes at different stages, but there was no conclusion because each pathology is very different. RV size, LV size can be very different. They've got different parameters. Even with tetralogy fellow, you can have a spectrum of disease, and you get different volumes, different, you have different function, and some RVs are restrictive, some are just dilated. So what they did indicated in this study was that everyone went back to their baseline after delivering, which is reassuring to know. And that makes imaging more important during pregnancy, because if you don't have the predata, then you have got nothing to compare. And if you don't have some echoes during the pregnancy, then again, you don't know after delivering if there's any problem, how you're going to compare things. So I think imaging is very important. Now, the echo, as I was saying, it's the most exciting part here. They've done lots of strain data, where they looked at LA volume, LA strain, LV volumes, and LV strain. Everything increases during pregnancy. But in this paper, which is very American-based, they did said that in the third trimester, things may deteriorate, but after delivery, everything goes back to normal. And we all know, I mean, they've done the radial tonometry, but we do know that your pulmonary vascular resistance drops during, or your systemic vascular resistance, sorry, drops during pregnancy, and they basically demonstrated the same findings. So it's all very reassuring to know that things do settle in pregnancy, but these are all changes in a normal person. So people with heart disease, I think, still remains a challenge. Now, MRI. So there are lots of changes that come during MRI, and as we know from here, your left atrial diameters increase, your ejection fraction goes up by 11%, and your end diastolic volume goes up by 21%, stroke volume and cardiac output also increase. But this paper was also very interesting. They noticed that if you do your MRI in a spine position, your volumes were far less. But in your left lateral position, which ideally we should have our patients in your second and third trimester when we are scanning them, the volumes were completely different. And this makes sense because if you're in your spine position for quite some time and you're pregnant, you're undermining your IVC flow and as well as aortic flow, so your volume will be left. And I think the take-home message from this paper was that you should be very consistent in the position that you're scanning your patient in, so you have continuity of care and consistent data. So if you're doing it in left lateral, do it in left lateral. Now, this is also very interesting. They compared MRI and echocardiogram together, and the rise in stroke volume, cardiac output, LV mass was very much comparable, as well as LV ejection fraction and volumes. But in this study, they demonstrated that the volumes, the ejection fraction, everything was underestimated on echo as compared to MRI, and the data from MRI was more reproducible. So again, MRI and echo can go hand in hand, and MRI data was very reassuring. But I think not the problem. I think it's the structure of any service. Access to MRI is a bit limited. And that was the CHIRP study, and I think that was very interesting. Now we can talk about CT versus MRI. I think most of the time we use CT. I think in my practice, I've used it for query for pulmonary embolism. It's very quick, very easily available. People are around to do it. It's not that costly. You don't leave your patient on your back for a very long period of time in MRI. They don't adjust in left lateral position, or they don't want to be on this. We don't want them to be on the back. But if you look at the data, it is very much reproducible, and the sensitivity and specificity over the years has improved. So it's not a bad bargain if you want to, if it's available at the time and you've got an inpatient who has to go for an MRI, you can have to go for a CT, you can go for an MRI. Similarly, from dissection, I think dissection is very easily pickable with some few views on MRI scan as well. And I think it was very interesting when I was training that we had not a non-pregnant patient that we'd done an MRI on. On the CT, we couldn't pick up a dissection flap, and it was a little dissection flap, and MRI was more sensitive. And then with the 4D flow, it really helped us to pinpoint where the entry point was, which was very, very interesting. So CT, I think, limits us quite a bit, but it's very easily available. MRI also helps with diagnosis of any type of cardiomyopathy. I think if you've got a DCM, you can do an MRI, you can very easily tell if it's this old or new. And if it's a new peripartum, your T1, T2 will be very different, or your ECV will be very raised. So I think it's a very helpful tool for diagnosis. I think you can do it while they're pregnant as well, but you cannot give them GAD, but you can get away with your MAPS, and that will help. Now, while I'm talking about imaging, why do we need all this? There have been a number of studies or risk stratification models for these pregnant ladies. There was a CARPEX score which was introduced in Canada, and it came from Canada in 2001, where they used 4 factors to risk stratify pregnant ladies and put the risk up. And I think they had a category of numbers 0, 1, and greater than 1, but the risk of morbidity was like 21%, 25%, 50%, and 75%, which was very overestimated and far too much. And then CARBEC 2 came in, which was had 10 factors, and out of that, I think imaging was the most important. And then we had the Zahara scoring system as well. While we had that, then we got the WHO classification as well as a part of the European guidelines, and this is which is commonly used. The last guidelines were in 2018, we got new coming out in August time. But what's interesting here is that imaging is a key factor, and what we find in imaging is extremely, extremely important. So again, we talk about WHO classification. There are 4 classes. Class 1 is probably no risk of dying and everything is pretty good. That can be your simple ASD, your PDA, a bit of an bicuspid aortic valve. I'll probably put that all in this class 1 category. Then you've got class 2 category, which is there's increased risk of maternal mortality. You can basically, as a classification, I can say you can have an ASD with some borderline pulmonary hypertension. Then you have significantly increased risk of maternal mortality, which is your class 3. And you can easily make your class 2 to a class 4 if they develop pulmonary pregnancy-induced hypertension or preeclampsia and eclampsia, or they have a twins pregnancy. So things can dramatically change as you have some external factors added to it. For me, the worry is your class 4. Sitting through pregnancy is quite challenging if they decide to go against your advice. And that includes pulmonary hypertension of any cause. It could be LV dysfunction, peripartum cardiomyopathy, severe mitral stenosis, Marfan's, as we know already, if they have a dilated aortic root, and severe native coarctation. Again, this is just to show that if you're class 1, your event rate is between 2.5 to 5%. If you're class 2, it's 5.7 to 10.5%. 2 to 3 is 10 to 19%. Class 3 is 19 to 27%, and class 4 is 40 to 100%. And I think we should be counselling all these patients. I mean, if you in a clinical practice, how much I use these guidelines? I don't, to the same extent, I would say. If I start quoting these numbers to my patients, I'll be scaring them off. So when you counsel them, you have to put it in such a way that they do take the message home and understand the risk, but not with the number to scare them off or cause anxiety, because pregnancy should be a pleasant experience, not a source of anxiety for them for the 9 months that you're going to kill them with stress. So you have to be very polite and you have to be very diplomatic how you're going to put things. And most important, there's a very, very nice paper. I don't know if I put that in here. It should be somewhere here. No, I haven't. There's a paper that they compared the CARPAG-1, CARPAG-2, Zahara, and WH scoring system. They risk stratified them and they looked at the event rate. The closest one was the Zahara scoring system that they matched up with numbers, and rest of them all overestimated the outcome. And in my own experience, when I have been doing this for the last 8 years, I think we overestimate the risk while the risk is not there. But I can also be biased about this because I provide 24/7 care for them. So I see them very regularly, I address all the issues, and I don't see that number of morbidity, but they're in a very dedicated service where they get to have seen by a consultant each time and everything is streamlined. So maybe that's the case, I don't know. But those scoring system, apart from Zahara, everything was an overestimate. So let's talk about practical approach, having had enough of literature. How are we going to do this? Know the physiological change in pregnancy, which we have spoken about. Know the patient in front of you. How to risk assess and counsel your patient, and I think that's very important. And know your MDT team. So you can't be on your own and say, actually, I'm going to run the show. No, you need to have a whole team for that. You need every single person to be party to it. So you're not the one who's blamed. Now, for preconception counseling, I think history is very important. You need to know the background. I think your clinical assessment at the time is very important. You may get an exercise test depending upon what category you're looking at. If I'm looking at a class 3, maybe someone who's got, let's talk about someone who's got some pulmonary hypertension, which is a moderate category, and they come to me and they said, I want to fall pregnant. I would like to know what's their exercise test like, how much saturations they drop, how much they put the heart rate and their blood pressure up. Imaging is very important to see what the cardiac function is like and what the pressures are like. And in most cases, which fall in 2, 3, and 3, I stress echo them. And I have found stress echo very, very helpful. For example, if I got moderate to severe aortic stenosis and I managed to exercise, then they had a good heart rate, no blunted blood pressure response, and I look at their echo and there's not been a dramatic gradient change, then I'll be quite happy to sit them through pregnancy. There's a good contractile reserve, and I will say, actually, that's pretty good. Let's get them through pregnancy. And actually, I can predict at what time, what's going to happen, because it's very much heart rate driven, because as soon as your heart rate rises, you can tell if there's any changes and where your blood pressure's gone up and where your gradients have gone up. So I find it very useful, actually, and I feel very reassured. I sleep better after doing that, and when I'm putting a high-risk case during pregnancy, so I know what I'm getting myself into. If you've got a complex congenital case, for example, if you're putting a Fontan case through pregnancy, and they have got a lateral tunnel, and if you don't have any updated imaging and you're not sure, I think I will scan them. I would like to know that there is no tunnel anastomosis, stenosis anywhere. And that has happened to me before, not with a pregnant case, but with someone else. And then the lower end of the tunnel was very stenosed, which got picked up on an MRI scan, and we ballooned it. But you don't want to do it with a pregnant woman. If you don't have an MRI on that person for the last 5 years or 3 years, get and do one before you put them through pregnancy. CT scan will only come into play if you have a complex patient and they've got a pacemaker, or their old pacemaker when they have their abdominal pacemakers, and femoral lines are all pacing leads, then I would probably do a CT to look at the anatomy. And if I don't have any consistent data in terms of the aortic root from MRI, and if it's always been the CT, then I would do another CT to see where things are. But it all depends upon what is walking through the door. There's no blanket cover for each of these cases. They're all very different. So let's talk about this case. This is one I looked after last year. So I counselled her 3 times. So she was a 32-year-old lady, had HOCM, severe phenotype. And apart from that, the BMI was on higher side. She had hypertension, she had myasthenia, she used CPAP at night time. And there's a family history of sudden cardiac death. It doesn't stop here. Half of the family member had renal transplant and very high risk of hypertension. She was on about 3 or 4 medications for that. So she comes to me and I said, no, pregnancy is not very good for you. I don't think you should do that. Wouldn't listen. And then I said, okay, if you would like to go for pregnancy, let's do an ICD. And she would say no. So as you can see from this baseline echo and MRI images, that she had good going HOCM. And then while she did not agree to the first counselling episode, she bluntly refused. And I think it's very important that you reassure your patient that what you're doing is in your best interest. And I said, okay, let's do some more tests and then we will see what happens next. So we ended up doing a stress echo, and as we can tell from here, she had a good contractile reserve. There was no evidence of any ischemia at all, but if you look at the gradients, they went up. The intracavity gradient went up from 35 to 84 and 94, and that was challenging. She had a very small cavity, and putting her through pregnancy would have been challenging because she cannot put her cardiac output up, and that would have been a problem. But nevertheless, she decided to go for pregnancy. She'd done well. At 16 weeks, we started having runs of ET, and then we counselled her that we need to give you an ICD. So we'd done a subcut ICD during 16 weeks for her because she would never agree to it. Then I said to her, look, I mean, it's again how you approach. And I said, look, I can deal with anything else for you, but what I can't deal with you dropping dead outside. And you're not just compromising yourself, you're undermining the baby. While you have decided now, I think you should go for the right treatment. And we had this, and she delivered around 35 weeks, done well, had a baby boy, but now she wants to have another one, and I'm hiding. Honestly, so now let's talk about complex congenital. Now this one is one of Professor Dimopoulos' complex case. And it's a Fontan circulation. If you look at the anatomy, it's a cytosolitis dextrocardia. I mean, I can transposition of the great arteries and have a small restrictive VSD. But on top of that, while she had a Fontan circulation, we'd done a TCP, we got complex anatomy. And then I think she was blessed by God. She also had HCM. So the left ventricle is thick as a chunk, as you can see here. And with the small VSD was offloading that little ventricle we had, and again we counselled her against pregnancy. She became pregnant, and we looked after her. The reason I'm showing this case, I mean, people do say no to you. You can do whatever you want to do, but if they want to have a baby, they want to have a baby. They wouldn't care. And I think this case was interesting for me, and I have to give it to Wei Li, who's our echo person. We got this patient up to 29 weeks. She was doing well, baby's going well, and then I got a phone call from Wei. I'd scanned this lady. This direction of the shunt has reversed. Because initially when it was shunting from left to right, from that small VSD, and now it's going right to left. Isma, do you mind delivering that lady? And I was like, ooh. So echo helps a lot, because if I would have not done the echo, or if Wade didn't call, then I was only going to go and look at the images when I was going to see her next, then that would have been a bit of a challenge. So that's why I say if you have a pregnant case, imaging on serial basis is very, very helpful. And then postnatal time was horrendous for me. I had in many times with our infusions, optimizing her medication. It took me 6 months to get her settled and hand her back to Costas. So, and sometimes you get the unknown. I was quite junior at the time. I had this lady come to a maternal clinic, and she had the diagnosis of idiopathic pulmonary hemosiderosis. Each time when she was on a high, she used to come in with pulmonary edema, and they done bronchoscopy, and they found some red cells there, and they said, oh, she's got idiopathic pulmonary hemosiderosis. She came to the maternal clinic, and I was with one of my bosses, and they said, oh, we can't fit her through pregnancy, she's going to bleed each time. And then we looked at the background history. We said, oh, she had TAPVD. So actually, we said, actually, let's do an echo and let's see what's going on. And then we found out that basically the confluence behind the LA was quite stenosed. So it was behaving like mitral stenosis. Every time when her heart rate went up, she went into pulmonary edema. and then the MRI was very, very helpful here because you can see the anatomy. And then we ended up ballooning, and then she was able to have a baby. But then my boss made me present this case in the grand round, and the respiratory physicians were not happy. They had me in the corner afterwards. I was like, you have to go to Lisa. So, I mean, what I learned from this case is that you need to go back and look at the history. Your surgical notes matter, the history matters. You can have the whole imaging modalities in the world, but if you don't know the background, you can't make the right diagnosis. So it's very simple things. Now, let's talk about pregnancy. Now, we're going to go by WHO classification. This one makes me yawn. This one is class 2, worries me a bit. I don't know why the classes are not coming up. Either they should do. And this is my class 3. But these are sort of cases which I feel we're quite comfortable managing. I worry about this one. One of the reasons I worry would be if they do have a PDA and pulmonary hypertension, your lower body saturations are going to be low. You need to have saturations more than 85% to grow a good baby. Otherwise, you're at high risk of miscarrying most of the time. Now, this is one of our other cases. Are we not moving? Oh, as I said, something's happened to it. They should have come at the same time. So now this case, we have delivered this year. So this is someone who has a very large AST, severe pulmonary hypertension. The RV is severely impaired. She had 3 spontaneous miscarriages with me, and then she became pregnant and would like to have a baby. This was my class 4, and it was very challenging. We started off with inhaled prostacyclin, IV prostacyclins. We delivered her around 32 weeks with ECMO sheets in, everything in, and I have to say that we've done well. She's got a baby which is 6 months old now, and she's doing reasonably well. I don't know what's going to be her long-term outcome. But that's where we are, and we can't stop people from becoming pregnant, even with complex disease or we're being very high risk, but all you can do is support and plan. And I think this lady done very well because we had a very cohesive team, where we had the cardiologists, obstetricians, pulmonary hypertension team, anaesthetist, we got cardiac anaesthetist, obstetric anaesthetist, and the way it was planned, I think we scraped away. But the postnatal care was also quite challenging, her going into some heart failure because of the fluid shift, diuresing. There were a number of issues. And I think for me, what's the exciting part, or what the interesting part is the Grushin line that we use for prostacyclin, how that has been looked after, because even changing or messing up a little bit can cost her life. So you have to be very dedicated to look after such cases. Ideally, they should not be pregnant in the first place. So these are regurgitant lesions. I normally don't care about them. I think they're fine. But at the same time, I was saying to you, if you've got severe pulmonary regurgitation and your RV is dilated, what happens to them in the long term, none of us know. And I think there should be more research. Now, stenotic valves are a bit of a problem. We've got a case with mitral stenosis. And in this case, the peak gradient was around 42 with a mean of 26. But she was pregnant when she came along and quite ahead in the game. Very worrying features. I'm so sorry, I think there's a bit of a lag now. And she had some element of post-capillary pulmonary hypertension because of left-sided heart disease. But with beta blockers, slowing her down, some furosemide, we got the gradients down to 21, the peak, and the mean to 12. And we sat her through pregnancy successfully. And I think it's very interesting that once she delivered 6 months postpartum, the gradients mean was 6 and your peak was 12, and it all settled down very nicely. I think with mitral stenosis, especially if it becomes rheumatic and you don't really have any regurgitation, there can be a plan B that you can bail them out with mitral valvuloplasty. I've done that before when I was, I think I was a trainee at the Brompton, we had a case. But I think the problem becomes when there's no bailout plan. So I would say that simple regurgitant lesions like PI, I don't bother, but with the aortic regurgitation, mitral regurgitation, if they are there, I think that should be fixed if the cardiac function's down and there are dilated ventricles. If not, then you can manage them with some medical therapy. So I think this one is very important. This is all about mechanical valves. If your anticoagulation is not very well managed, you can run into lots of trouble. This is a study that was, I think this is quite old. This is not the case at the moment, but I thought it was quite nice to show that you can have high maternal mortality if your anticoagulation is not up to mark. We normally use Clexane and with monitoring factor 10A levels on a regular basis to make sure that we're within normal range. For mitral, we have different. For aortic, we have different. Some centers do add aspirin as well. You can do BD dosing, and some centers, or the American is that you can do TDS doses, but that's not very pleasant for the mother. I think if I look at the paper from Brompton, I think Lorna was involved. There was lots of comorbidities, but the mortality was low as compared to what we have in this paper. Now, I think we don't want to forget about, we're talking about heart. We don't want to forget about the aorta. So we have to think about aorta. If you do have dilated ascending aorta, you have aneurysm formation, think about it and get that sorted before they fall pregnant. That's the last thing you want to have any mortality. Again, we were talking about PAIRS and Marfan syndrome. We are coming into the practice now. If we do have females now, we do PAIRS first before we're sitting them through pregnancy. Is there a right thing to do or wrong thing to do? I don't really know, to be honest, because the data is not there. I will show you the data we have for the 9 cases that we sat them through pregnancy, but so far it has been good. But they do need regularly monitoring during pregnancy. We need to know what the aortic root is doing, what's happening to the rest of the aorta. And in most cases, if I do see some change, if I'm unhappy, I do an MRI in the last trimester to make sure everything's fine, especially prior to doing the delivery planning. Now, this case was very interesting. This was a type B dissection who had 2 children before. And then she decided to become pregnant again. She was told by her physician, oh, it's okay, you'll be perfectly fine. She had a type B dissection, had 2 stents in, and there was a coarctation which was not stented, although it says stented here in the notes, but it was not stented. You can see up here, the coarctation is still there. The stents are possibly there to seal off the type B dissection. So she came along, pregnant around 22, 23 weeks, didn't tell us anything. And then the way we monitored her, and she's also hypertensive because of a coarctation, which is not stented. So we managed her. Echo was no good here. I'm sorry. I love echo, but it was no good here. And MRI has been very, very helpful. As you can see from these images, we were able to monitor the size of the false lumen, where the coarctation was there any further dissection. So I thought it was very helpful. And the bottom one is post delivery. She's done well. We make sure that we snip the fallopian tube at the time of delivery and no more babies. So she's done well. So, I mean, I find pregnancy and heart disease very exciting, provided you don't have any deaths or any serious comorbidities. So I think it's an interesting entity. These are some unknown cases. This is someone who presented with some shortness of breath and low saturations. This person was from another hospital, was transferred to us. Basically, she had an AP window with a VSD and severe pulmonary hypertension. We delivered around 32 weeks. We've done well. Then we had another exciting case. That lady who came to us pregnant around 36 weeks. She said, oh, I can't lie down flat. I feel very short of breath. And basically, she had a fibrillostoma on her aortic valve that when it was flipping back, that was causing her symptoms. So we delivered her, and then we dealt with the fibrillostoma afterwards. And MRI was very, very helpful here in this situation. Now, also, cardiomyopathies, as I was saying before, MRI really helps. You can tell between acute and old cardiomyopathy. I had this case where this was the 3rd pregnancy. And it got unmasked during delivery, and all this was dealt in that way. She had an ejection fraction of 10%, and she got transferred to one of the transplant units, Imperial, which was our sister hospital, but we managed to send her home, and she's listed for transplantation now. I think for me, this case came to me as a second opinion. So this case is not mine. It was delivered by one of my colleagues at Barts. They had a 35-year-old lady, gravid 3 para 2. They gave spinal anesthesia at the time of delivering, and she developed pulmonary edema. So basically, it's not playing nicely. So basically, the apex and the mid part of the heart was contracting very well, and the base of the LV was completely gone. And the treated settled the patient at the time, delivered the baby, and when you looked at the imaging next day, everything was back to normal. So it seems like, or more or less near normal, she had reverse Takasubu at the time because of the spinal anesthesia and the stress we had. And the reason I had her, she came as a second opinion for preconception counselling and see if she wanted to have another child. And Kate, who's my colleague at Barts, asked me, what would you do? And I thought, clearly I wouldn't give her a spinal anesthesia, but I will beta block her because it's most of the time it's adrenal surge. I will beta block her, I let her go through pregnancy until she understands the risk. But again, I would say, none of us know what you're going to do with this case. You have to just pragmatically organize yourself and risk stratify and see where you are with things. Now, again, we were talking about MRI. I think I find MRI very helpful in acute stages, peripartum cardiomyopathy. I think it tells you exactly what's going on. I think I've got a case now, so it's going to be questions. So let's talk about case. This is one of my ladies who sat through pregnancy. She had Al-Kappa. She had significant mitral regurgitation, as all do, with a dilated left ventricle. She had a Takeuchi repair in 1994, spent 3 days on ECMO, done well. Takeuchi repair is that, who don't know, that you tunnel the left coronary artery through the pulmonary artery into the aorta because your left coronary artery is coming off from the pulmonary artery. It's a quite fascinating repair, and she had a little fistula. Over the period of the time while she recovered, but then the mitral regurgitation became a problem. So we replaced the mitral valve with metallic valve, and again, she had a traumatic course. We've been on ECMO long-term for a couple of weeks, and then she recovered. We had some problems with atrial tachycardia. We gave her amiodarone, we settled her down, but this left her with the ejection fraction of 48%. And they done a cath after doing the mitral valve. I don't think so it was the right time to do it, but they said there was some element of precapillary pulmonary hypertension. And there's a whole list of medication she was on. So what should we do now? She's come to me in the clinic and she said, Isma, I want to have a pregnancy. And what should I do? Should I say no, or should I say yes? Let's talk about the imaging. So that's her echocardiogram. Metallic prosthesis is working well. That's showing the fistula. You can see a bit of leak. Again, short axis to show you the cardiac function. You can clearly see that's impaired. And you can see that the metallic prosthesis is working fine. And the gradient across that metallic prosthesis were perfectly fine. So we got the baseline imaging. You know that ejection fraction's down. Your metallic prosthesis is working perfectly fine. You got a bit of a baffle leak to the Takeuchi repair. And then what should we do next? What would you like to know? Shall I say it's okay, you should go and have a baby and you're going to be fine? Which class it will come in? Probably class 3. So let's move to my next slide. So no one's going to volunteer for me? Very good. But before doing stress echo, what I would like to know, how can you do MRI and not say MRI? So we had an MRI scan, and we looked at anatomy very carefully, making sure that we're not missing anything. And then on late GAD, we did have some infarct. We normally do get that with Al-Kappa, but it was not really extensive. And on the MRI, we got an ejection fraction of 59%, but that was all on medical therapy. So we stopped her medical therapy and then we stressed her. So when I stressed her, she had a good contractile reserve. She exercised well. The heart rate went up. to about 167, and LV responded beautifully. There was not dramatic changes across the metallic valve prosthesis. It was functioning perfectly fine. But what caused me trouble here, that her RVSP went up to in its 50s, which was a bit baffling for me. But then when I looked at the heart rate, it was more heart rate driven rather than actually a problem at that time. So we counseled her very carefully and we let her have the pregnancy, and she done remarkably well. I mean, her cardiac function maintained. I didn't really have much problem. In the last trimester, it went down. We had to add some furosemide. She was a bit breathless. Metallic prosthesis, anticoagulation was up to mark. And she delivered around 36 to 37 weeks with a very healthy baby. We saw her postnatally. That was 3 months after, and I think it was still borderline impaired. But 9 months after delivery, everything just went back to its normal. And I can show that in this cross-sectional view. And she's done remarkably well. And I'll be quite relaxed too if she wants to go through another pregnancy. And if she wants to take the risk, I'll be happy to sit her through pregnancy because I do know how she'll behave. And I think, as you quite rightly pointed out, stress echo is very useful. I don't know about you all, but it gives me a peace of mind and I can sleep better when I have such high-risk cases. Now, what do we do post-delivery? I think that's an important question. I don't care what imaging you use after once the mum's delivered. There's no risk. Use whatever you like, depending upon the clinical scenario. I think if you're going to give contrast, you have to be careful with lactation. The policy is that you don't let the mum breastfeed for 24 hours, you express. But at the same time, when you look at the literature, the amount of dye that goes into the breast milk is about 0.04% of the dose of GAD you have given, which is very, very small. But despite that, we say don't breastfeed for 24 hours, just express the breast milk and get rid of it, and then start afterwards. And I think postnatal care and follow-up is very important here. Now, this is my diagram. I like to do things this way. So depending upon my case, which is usually class 2 and class 4, I like to do preconception counselling. I take their history, see what their physical state is, examine them, look at their echo, and if I'm concerned, or most of the time I do a stress echo and see how they behave, what happens to the LV, what happens to the RV, depending on what side of the lesion it is, what happens to the stenotic valve, how things modulate. For example, I don't know who I was telling, I had a single ventricle, systemic. The ventricle morphology was right ventricle. There was systemic right AV valve regurgitation. She wanted to become pregnant. I said no. And I said, let's go with stress echo. As soon as we done stress echo, she went into VT. There was no contractile reserve. Where we were talking about pregnancy, we ended up on the transplant list and with the tri-clip of the right AV valve. So I think stress echo helps quite a lot. And then if you're not sure about the anatomy and if you're not clear about what's going on, cardiac MRI is very, very helpful. You can let them fall pregnant, and most of the follow-up is with echo, and MRI comes in special circumstances, I shall say. Class 1 and 2, I don't think you need to be that stressing about it. You can just get away with an echo with good history, and they're usually okay. So at the end of the day, if you're not sure about anything and you strongly feel clinically, do what's right for the patient. Don't worry about the radiation. I mean, Sarah Thorne basically says to me that if you do one X-ray, you're just spending 1 day in Cornwall. If you're having a CT, you've done 1 month in Cornwall, so it's fine. So just see what's best for the patient at the time. Again, I think this is how a service should look. I think preconception counselling is very, very important. You risk stratify your patient. Are they suitable for pregnancy or not? Then you decide if they're going to have pregnancy, and if they do, you're going to monitor them in a dedicated service, so you know what's going on, how you're going to deal with any signs and symptoms. If they're deteriorating, you do all that, and then you do the delivery planning. That's extremely, extremely important, that how you're going to deliver them, what you're going to give, what you're not going to give. And then postpartum care is extremely important. 6 weeks is a good time, and even 3 months is a good time. And then they go back to their respective consultant. And I have to say there are a high number of people involved when we are delivering the service. There can be everyone from each speciality to help us out. And there can be weekly clinics. And I think it's very important that there's an MDT process where all the cases are discussed. Now, while we are very, very considerate about the mother, but if the mother's happy and healthy, you will have a happy baby. But don't be alarmed if you've got low birth babies or small for gestational age. I think these sort of things can be addressed. They grow once they come out if they're managed effectively. I think the problem is when they're extremely premature, when 24-weeker or 26-weeker, where that's where the issue becomes a big challenge. But we should try very best that the factors that we can modify, we take them away. This is our Embrace study that we use in UK, and we looked at maternal mortality from cardiology. And it has been high over the years, but despite having these clinics. But I was speaking to one of my colleagues who sits on the panel. I do the clinics with her, and she was telling me that the numbers in cardiology have gone down dramatically. It's more obesity, which is causing problem at the moment, or socioeconomic state, psychological state. Mums are driving into trees, or there are lots of confidential case reports that came up, but we don't have that much cardiac issues as we used to have at that time. And so I think this is very important to highlight, that things do improve when you have a dedicated service, the mortality is low, morbidity is low. It can be challenging in unknown cases, but if you have the right alerts in the place that someone refers a case, you can sort them out. I thought this was interesting. It was a very financially driven study from America, and they have basically mentioned it can be quite a costly business if pregnancy doesn't go well with the mother and the neonate. I don't think so. I will dwell on that. This is my data, or our data from the Brompton. This was a BSc project for one of the medical students, and these are amount of patients. We see 1,031 patients in about 16 years' time that we counsel them and put them through pregnancy. Class 4 is quite a few there, as you can see, but all received preconception counselling. And there's still, despite all this, there's quite a big number that we don't get to or they don't have access to us. These are my class 4 cases that we had 33 pregnancies that we delivered at the Brompton in cardiac theatres. There was a mix of things. Predominantly, they were pulmonary hypertensive cases who we delivered, and the rest were coarctation or heart failure. We had no deaths, which was reassuring to know. But the hospital stay was quite long. Heart failure and arrhythmia was on the higher list. So this is in for publication at the moment, so hopefully that shall come out in couple of weeks' time. So I think I was talking to one of your colleagues at PLC yesterday who looks after Marfan cases, and I said that we are doing the pairs. So this is the data from one of the things which is, I think this has been submitted at the moment, that we had 9 ladies that we have put through pregnancy with pairs. But I don't think there's long-term outcome. I think we can only say that 4.7 years that they all done well. There's no further dissection, there's no type B dissection, but when you look at the literature where other people had pairs done, there are 2 cases which are picked up where they had type B dissection. Is that related to pairs or not related to pairs? I don't really know. My own understanding is that you're fixing the just top part, the rest of the aorta is going to be the same, and it doesn't take the risk away. But in our data, we have not seen anything to suggest that pairs has been good, but we haven't had any adverse outcomes in terms of type B dissections. But I have to say they're very rare anyway. It's 1% pregnancy related. This is one of our Fontan series that we published. All our Fontan cases done remarkably well. And this was, we basically trying to set up our specialist nurses to help all these ladies, how to counsel them, how to plug them into services. So that was something on this lines. This is our pregnancy outcomes in Fontan circulation, which was very reassuring. But again, we say that we had the short-term outcome, we had the medium-term outcome, we don't really know about the long-term outcome. Again, we had no mortalities in our data when we looked at it. This is one of our recent BSc student who looked at all the echoes for me and changes during pregnancy in aortic valve disease or left ventricular outflow disease. So that should be out soon. We also have looked at systemic RV outcomes as well. CCTGAs and musters and sennings. I think the latest data was from ROPAC, where they looked at 172 cases, but that was at 6 months outcome. We got up to about 15 to 20 years, so that's all also in making. I would say that pregnancy, heart disease, imaging is not a single person show. You have to have a whole team. I feel like I'm that dark green person at the back. So I'm holding the team together because you get everyone together when you have such cases. And when I talk about pregnancy heart disease service, it was started in 1982 by Philip Kilner and this lady here, Jane Somerville, taken over by Professor Gatsoulias. This is Chelsea, where we see most of our cases, and Brompton, where we have been delivering. We don't deliver at the Brompton now. We go to Guy's and St Thomas's. These two are still partners to my to the service with me. Lorna used to be there. I took over from Lorna. Lorna's part of the guidelines, and I've learned a lot. Wei Li, I mentioned, is very, very, very helpful with imaging and echo, and where I feel, okay, now I'm stuck, let's go and speak to Wei. So she's a part of my pregnancy heart disease team. So we all are very lucky to have them there. So I shall say, we can't, I mean, you cannot 110% follow the guidelines. Each patient's very different. There should be individualized, tailor-made care for them. And that has to be, you can follow a pattern of it, how you're going to do it, but each patient is cared very differently. So be mindful of the fact that you just can't have a blanket for each patient. And I think that's what I picked up from my pregnancy heart disease clinic. Each case, if it's the same pathology, despite being the same pathology, the cases can be extremely different. And I thank you very much. This is me at gone to the mountains. I really enjoyed it with my family, so I had a good time. So thank you for inviting me.
Thank you so much for that great talk. We'll open the floor to questions.
Oh, do you want to?
Here, I'll just open the chat online here. There we go. Why don't we start with the online chat questions?
So I have to say that we normally don't come across with that much. And when we mean fibromuscular dysplasia, can there be more specific?
Youssef, are you still on the line there? Do you want to just speak up about your question about fibromuscular dysplasia?
They've never been sort of like shuttled to our clinics, and I don't think there's been any risk of any death.
Yeah. I don't have a microphone.
Sure.
Questions in the room? Oh, thanks. Thanks, Lexi. There you go.
Catherine.
Catherine.
That was a fantastic talk. And I have lots of questions, actually. How long do the changes that occur in pregnancy before they return to normal? And how would that be affected by multiple pregnancies in short order? And how does age affect that?
Right. So the hemodynamic changes when you conceive and you're pregnant, you peak your cardiac output by 24 weeks. After that, there's as such no change from that point of view, apart from that the baby grows and your plasma volume and other bits and pieces changes. After 6 weeks, things do start settling down. By 6 months, you're completely back to your normal cell. We do not advise people to become pregnant on a short period of time, not just because of the cardiac reason that you just recovered from a stressful situation. There are lots of other reasons that your body's short of minerals, your ions are low, your folic acid is low, and then you're lactating and you have to bring the baby up. So we normally say that a gap should be 18 months. And as I showed in my first slide, were the modifiable factors, which we can't modify, is one of age. So if you're older age, you have much higher risk of causing trouble. And you develop pregnancy-induced hypertension, preeclampsia and eclampsia. And if you're of a black race, then you're in trouble as well, because they're more prone to hypertension, preeclampsia and eclampsia as well. So if you have got a Fontan case, they're young, the chances of them getting through pregnancy when they're very young, if they're saying they're turning 40 and they want to have a baby, good luck, I would say. So if you do have complex congenital cases, they want to have children, even you have DCMs and other bits of DCMs as well, I shall say go through pregnancy early rather than later. And I'll very openly say that to my patients. I hope that answers.
Yes. Another question I have is, if you've got someone with a cardiomyopathy and they're on GDMT, okay, and they want to get good guide-directed medical therapy, and they want to get pregnant, which of those medications can you continue? Which of those are a no-no?
That needs to come off. The only medication during the pregnancy, I'll keep them on beta blocker. and a bit of aspirin. Everything will go. If I really need to introduce diuretics, I will introduce furosemide after the 12 weeks. I'll be very happy to do that, but the rest of them, most of the medication needs to go. I'm very happy giving lots of other medication like sotalol, flecainide, digoxin, other bits and pieces, but all the rest, a heart failure medication cannot be part of all this. Same applies to pulmonary hypertension medication. Sildenafil is very safe. In some cases, tadalafil, I will, but I wouldn't recommend. But then the rest of the medication that you use for pulmonary hypertensions, I would completely avoid them. They have severe tragedic effects. Now, after delivery, we can talk about that. If you want to put them back on heart failure therapy, you have to be very mindful of the fact that most of the medication you can't give while they are breastfeeding. So that's a bargain with your high-risk case that can you please not lactate and bottle feed the baby? And we can put you back on your heart failure medication. But again, it varies from case to case. And I normally say, I mean, lactating is very good. We should encourage that, but I'm a bottle baby, so I'm 6 foot tall, doing okay. So it's all right.
Online there, why don't we do that one?
I think we do use bromocriptine, but then we can't breastfeed, but you have to be very clear. And we also use garbalgine as well. Anticoagulation, I'm fine with warfarin. We are fine with clexane. We cannot use rivaroxaban or apixaban, so that's contraindicated in lactation. And you would not give that. So you probably have to go for warfarin. Bromocriptine, once you started that, you can't breastfeed anyway. And if you're giving bromocriptine to someone with DCM, it means that the breastfeeding should not be there, because there has been some research study that when you're breastfeeding, they've done it in the rats, your cardiac output goes up about 2 to 3 liters. I think that's I can fairly remember. So if you want to breastfeed you with a DCM and you're putting your cardiac output up, you're making your LV struggle. So we normally advise not to if you have severe impairment. Someone with an ejection fraction of 10% will say, for goodness sake, don't. And same applies to some of my systemic RVs as well. I would advise not to.
Thank you, Rafiq, for your excellent overview. I had 2 very quick questions.
You can have them long, I don't mind.
First one is more of a practical question. So patients with pre-capillary pulmonary hypertension,
Yes, idiopathics.
and they are sort of gravida 1, para 1, how often would you do, in terms of their management, how often would you do their imaging? Sort of baseline, and then would you...
So you have the preconception imaging. You also have a right heart catheter. So I would not just go by the data that I have from echo. I would like to have a right heart catheter. I would like to know what my wedge is, what my PA pressures are, and is there any reversibility? Now you asked a very important question. There's some part of idiopathic pulmonary hypertension which is reversible, and you do the reversibility test with nitric oxide. And those patients normally respond very well to calcium channel blockers, and you can sit them through pregnancy very easily. So you have to be very careful when you're counseling this patient. If they have a right heart catheter with reversibility, then you're laughing. It's much more easier to sit them through pregnancy. But I think 1 trimester each is okay, depending upon the severity. But if she's already gravida 1 and para 1, I would say, actually, thank you very much. You had your 1 child, move on in life.
My second question was about stress echo. Do you mainly use dobutamine stress
No,
or exercise?
Exercise. I don't like dobutamine or adenosine in that scenario. Exercise is the best stress echo that we should be doing. So, yeah. I like ladies running on the treadmill.
One group you didn't mention was transplant group.
Yes, I forgot about them. We do look after them, but again, it's very challenging. I think we can't keep them on higher dose of sirolimus and other medication. You have to come down on the dosage. But I think the assessment's very important. If they don't have any graft host versus disease, some of them do develop coronary artery disease as well, which is a part of a chronic graft versus host disease, then that makes me negative about things, and I would say no. But if they don't have anything at all, I will let them have the pregnancy, but they should be mindful of the fact that they can have activation of that and their graft can go down. The risk is quite small. And the other thing they should also be mindful of the fact is that if they go via C-section or even vaginal delivery and they get tear, the healing can be quite poor because of the medication they're on. But yes, we do sit them through pregnancy, but only a handful of them. Thank you.
I'll take my opportunity for a question now, if no one else. You mentioned native T1 mapping.
Yes.
in this population. Are you actively using that, and how are you applying it?
No, we're not using it.
okay.
It's more literature based, and most of the case we've done T1, T2s, and we've given late GAD is after delivery. But again, I think it's a very good idea, and I think it could be a multi-center research program. So, but yes.
Yeah, haven't started.
No, I
using
haven't
it.
started yet, but this is just, I mean, when you look at literature, when you see your patients and you say, actually, we can do this, but then as the numbers are very small, it has to be multinational, multi-center program. Even when I was talking about the systemic RVs, where we looked at lots of data, I have to go to 2 other centers to get numbers up to in hundreds. Otherwise, the numbers are very small.
Mike, yeah.
Yeah, you mentioned 4D flow imaging. Do you use that?
Just for fun.
Same here. Yeah.
Great. Anyone else? No?
Okay.
Thank you very much.
Thank you so much for that great talk.
I've done that.